The master runner will typically demonstrate a higher cadence that is inversely proportional to step length. You'll also see a more flexed knee and foot position on striking, and reduced ankle, knee, and hip excursion during the loading phase. There's less vertical oscillation of the center of mass during running as well. And you also see a reduced or peak impulse on foot off. The first runner discussed is about a 6-year-old male, and we discuss the foot strike pattern and swing patterns of this individual. What we'll notice is that there is very little flight phase in the master's runner. The next case is a 55-year-old master athlete with you'll see the similar characteristics that were discussed in the first slide of the master's athlete. Certainly a flexed posture with running, a stiffness in the lower extremity, as well as what we notice, stiffness in the thoracic spine, which will transfer forces and load down into the lower spine. With the rear view, what we'll see is the increased hip adduction angle and pelvic drop on the left. What can't be noted is the hip internal rotation.
Look at when I do gait analyses are probably not as much of the innominate rotation and more of or I'll start at cadence, initial contact, whether like how far anterior is their initial contact, what's the position of their foot, pelvic drop, and trunk rotation. It's probably where I start and get a lot of bang for my buck. But then like Matt and I exchanged a few messages after last week being like, you guys are so smart. Sometimes we can't keep up with what you're saying. So having like the next layers of, or the nuances of pelvic rotation or innominate rotation in different phases of gait that's cool. Cause I learned it a long time ago and probably don't implement it as frequently as I do some of those other more like basic things. So that would probably be my initial thought, is that it was, I mean, that's the whole point of doing these, right? Is to like figure out where we're.
That's what it is figuring out what things you kind of want to work on. That I have here. I'll just pull some up here if I can. I'll pull up one of the quick presentations I've been working on. But the one I'd go was the easiest one to be the master's runner I've been looking at this past week.
Does masters just mean old?
Yes. You know, they define it in literature as over 35, but it's really bullshit. It's really not over 35.
No.
It's really like older than that, I think. Yeah. So master's runner is 35.
I would be masters in like 3 years, guys.
That is the technical definition, 35 and up.
Oh no. That's funny. Okay. I thought it was going to be like 55 and up.
Yeah, that's really where I would put it. I put it, you know, the running style change is more like in the 50s, mid-60s. Like I ran with Fred one time a couple years ago in Denver. And Fred's blipping along, moving well, looking good, you know, running me into the ground since Denver, and I'm at sea level. You know, so he wants to talk. And I can run with him, but I can't talk and run with him. Because I get too oxygen depleted. So I can run with him, but I couldn't talk and run with him. But I met him in Denver maybe last year, and I watched him run the treadmill. I'm like, oh Jesus, Fred looks old, because he had adopted that older running style.
Yeah,
somebody who's more of a master's runner, which I had not seen before when he was crushing me in Denver.
I bet he's fast. He's got like bird bones.
Yeah, he does have bird bones.
It's got all that extra wind resistance with the mustache, though, so it slows him down.
He's got like half of a pump, not as big as Matt's.
Pull it up. I'll pull him up. I mean, if you want to, we can talk about some of the distinguishing features of the master's runner. Good to get Eric's take on it. That's why it's always nice to hear Eric's view on things. You know, by the end of an hour, it seems like Eric and I were kind of on the same page. But the trajectory of what he's looking at it from is a different angle, which is always fun. That's where I learned a lot from this, because it's I see it from that angle now. I can look at it from the other side of the room.
Yeah, I think everybody gets their usual, you know, what's the driving mechanism? Where do things kind of instigate from? And you know, mine's probably different than yours. It's probably different than Fred's and Gail's. So you know, Fred's more like me. He's more biomechanical. He's more concrete about his stuff. Gail's more holistic. She kind of looks at the whole thing and then narrows it down.
Yeah.
So that's good though.
And maybe before we talk about that runner, because no one else is on this call, I am going to move to Alaska. And
Again?
so,
Again? Didn't
No,
you
I'm gonna
just
move
go to
there.
Alaska?
I'm going to move there.
Oh, nice.
Like, I'm going to like,
It's like the guy, the girl.
no one knows yet. Hey, I'm looking, I need an outdoorsy dude that is not bougie. And I'm not finding that in Chicago, okay? So I have, no one knows that here, so keep that to yourselves. And so I don't know that I will finish my fellowship hours before I leave. And a guy that I've been talking to up there he's the president of the Alaska chapter of the APTA, and they've got he's got a clinic with 5 fellows. And so the question is, will fellowship hours count if they're with fellows trained at
we'll get you through.
they're like Grimsby, Ola Grimsby or whatever.
We'll do what we need to.
Okay.
I don't think it matters like who they were trained with, as long as they are a fellow.
You know,
They know better than me, because I've done fellows from other institutes as well.
No, I mean, from a program standpoint, we've always had in-house people do most of it. But my thought is that was like, oh, well, is that person qualified to be a fellow when you get reviewed? And what have they done to keep up with their teaching skills and all this BS? It's like, here's what they've done. They become a fellow themselves. They've gone through the program. They've done all the mentoring. It's not like OCS or something else where there's no formal process. I mean, every fellow has completed a formal program in my eyes. So I think that's helpful. Like, what's hard is that like you're somebody who hasn't taken the program twice, and you go through it once, and that person's trying to teach you other stuff that's not in the program during the program. That would be a problem, because then all of a sudden you're getting mixed messages around. So that lack of consistency would be a problem. But for you, it's not a problem. You have enough experience.
Okay.
It'd be a good thing for you.
Okay. Cool. I think the timeline is probably like around 3 or 4 months. So we'll see. I have to like get my Alaska license approved and transferred, and who knows how long that's going to take depending on their staffing. But that guy, his name is Alec K. I don't know if you have ever heard of him or not, but
I know one of the Ola Grimsby guys is in Alaska. He comes out of there, and maybe one of the program directors of there, I think, is based in Alaska, and it's probably him, is my guess. I don't remember the exact name.
Yeah, it probably is.
In the Ola Grimsby program, being from Alaska.
Yeah. And I think he said 4 of the 5 were Grimsby fellows, except one of them who did her fellowship at UIC here in Chicago, which I think is like super small world. And I have heard that the UIC, I don't even remember who I heard this from, but I didn't hear great things about the UIC program, or I don't know if it was more
I think the little Filipino guy runs the UIC program,
evidence-based instead of I mean, I don't know anything about it, so I have to go change the laundry really fast so I can still listen. But the girl whose clinic is across the street doesn't have water in her clinic. She doesn't have a bathroom or a laundry hookup, so she brings it to my clinic to do it.
Your laundry?
So she just drops it off, and then
and you have to change it over for her?
Her towels and pillowcases for work, not her like underwear. Yeah, I change it for her, so it's like a 2-minute job for me, and it saves her walking across the street to do it. So, just trying to be a team player.
It's okay. Hey, Scott. I'm sorry, Scott. Eric, did Fred explain to you why we're going to meet tomorrow night?
Yeah, I talked to him on the phone on Monday morning, I guess. So we kind of had a brief conversation about it. I was running around the grocery store when I was on the phone with him. So
no problem. It's really just a brainstorm on fellowship and growth, and what are different avenues? We'll talk about just different ways to do it in the current model, but also could we look at the feasibility of whether it's just doing a 10-person or a certain person dedicated fellowship program,
Yep.
and looking at the math and the logistics of that. And also part of looking at the program as a whole and saying, we broke this program down as a whole. We literally, from the didactic portion, you break it down in chunks of hours. So if you look at the hours that you teach, 1 through 8, each hour has its own particular unit. You know, if you divide it all out, which units could be taught online effectively if we were to kind of trim a program down, what units are absolutely hands-on, and then, okay, where does that time base out? Can you restructure the program in some way? Or could you take somebody like, you know, I'll talk about it now, like a Rich Monaco with less experience, probably not quite ready to teach in that capacity, but he could do the skill side of it and do that. And then could you start matching didactic with people? So, you know, you could look at early started being like, okay, maybe there's one in Baltimore, one, you could put one in Beckelo in Nashville, and could you kind of push this cohort model that way, or then can you kind of even get a even bigger different thing? So it's not really a set in stone thing. It's just more of a, can we do it? We have the basis for mentoring, and we can do 50% of the mentoring of what we're doing now.
Mm-hmm.
You know, you can kind of do that. That way, the cost of the program could potentially pay for, you know, again, the person to teach, and then also paying for the mentoring time to an instructor like yourself.
Sure. Yeah, no, I told them I was all for it. I mean, anything that we can do to, you know, increase
create more opportunity for yeah, I think it'd create more opportunity for you as well as me, people. So just to kind of, you know, brainstorm just around that a bit. If it's just easier, the three of us.
Yeah, definitely.
Jim always kind of goes sideways on certain issues. So it's better just to think about it. If we looked at it a certain way, could we brainstorm to come up with okay, that may work, or this might work, or maybe we'll look at that hour by hour modular system and see where it ends up, and maybe it doesn't pan out. But my guess is we could streamline in some ways or just modernize.
Sure. Yeah, I think we can make it. I think we can make it happen. But yeah, I think it's probably good to actually have like a actual discussion about it as opposed to doing it over 35 emails.
Yes, that's why I figured just get a couple of Zoom calls going. You can meet, discuss about it, and say, okay, this is maybe what we'll look at on paper. And we can look at it on paper and say, okay, do we go to the next step with it?
Cool.
Because if that's the case, and Jim's hung up on the clinical reasoning side of it, it's okay, Jim, record 5 clinical reasoning hours for each module. You know, do a Zoom session like this with fellows or somebody and go over those tough cases that you find are the core of each module. Those could be 5 hours delivered by him, or if he's like, now the clinical reasoning portion has to be a certain way. You know, just to figure out different ways to deliver.
All right. I'm sure we'll work something out.
That way Kara could start a program in Alaska. She gets up there.
Yeah. They'll be nice and saturated up there with, you know, 6 fellows all wandering around in the same hallways.
Yeah, exactly. More fellows per capita than any other state in the country.
There are. Like, there's basically a main drag, and there's no athleticos. It's all like private, you know, people own 2 or 3 clinics, and almost all of them have a fellow or OCS or a resident. So I was actually pleasantly surprised.
Freaking nothing else to do.
That is so wrong. There's so much to do. Even in
especially when the day is 22 hours long.
It's winter for 6 months.
Yeah, just
I'm
think
not
when
afraid of cold weather.
You're complaining about working 13-hour days. Just wait till the sun's out for 22 hours. You have to be in the clinic for 18 hours a day.
Yeah, right. Dude, Alec was saying, he was like, the reimbursement up there is really good. And he's like,
anything is good compared to where I'm at.
Yeah, absolutely.
I mean, I wonder what yours is compared to Chicago, but
way worse. We're the second worst in the country.
How many people do you see a day usually?
Well, here with the whole COVID thing, I'll see anywhere from 10 to 11, 10 to 12, maybe something like that.
Not bad at all.
But at my last job, when I was working with PRN, which is kind of similar to an Athletico, but more West Coast based, I was seeing 25, 28 every day.
That's a lot.
We were averaging $62 a patient for reimbursement.
Oh no!
At my clinic, yeah, it was awful.
That really sucks.
Yep.
I heard net revenue per visit in Alaska is like $180. So Alec is like, you should not settle for anything less than one-on-one. And I'm like, well, that's great because I got 5 patients in the clinic most of the time around here. So that's exciting, but and the salaries are really good, which is
Yeah, I'm sure.
also
Yeah, way to rub it in.
incentivizing.
You'll save some money.
Please. Oh, please. I'm sure you guys are doing just fine.
You have nothing to do up there. You'll save plenty of money.
I will only entertain those comments when you've spent more hours there than I've spent.
Here's the other thing too: is being the only girl in town. The first day, you have to buy yourself a drink. That's the day you have to leave Alaska, because you've now aged out to a point where even you aren't attracted to the guys in Alaska. So the first day you buy yourself a drink at a bar, know that, okay, my time here is done.
Mm-hmm.
Or you have to move up further to the bush where the standards have lowered. Okay, so your two options when that happens.
I can't wait to talk to you guys in a year once I've settled in there and it's 18 hours of sunlight all the time.
Yeah, you'll have a beard.
I really hope not.
Or I get too tangential.
Right,
Can you see a dirt pavement or asphalt? Not a great video. You see how it runs. Yeah, I'll pull the other one.
Well, I was going to say, I don't even see a runner.
Ooh, hold on. Let me come back. I had something funky happened. Hold on. There I am.
Mm-hmm.
Okay, I'm there.
I'm going to mute myself so you guys don't have to listen to me chew. So sorry about that.
Look for the other video. This was, I was getting example videos of a, let's see, no, my screen's not sharing. Let me share screen. Getting sample videos. One of the things I was doing was putting a couple Masters runner slides together. So to pull this up, I'm gonna try and clean these videos up, but you know what you'll see in the Masters runner is kind of a classic, they all have the same kind of classic running style where you get a lot of stiffness in the joints. It'll slow down in a second. You kind of, generally what you'll see is ankle stiffness, knee and hip. You get a lot less excursion in them. You'll see it, so you see a lot less recovery. This guy actually did run training with me for a while, so his recovery is not good because he's practicing a higher recovery. When I initially saw him, he was getting a lot of lateral knee pain in his right knee. And he was basically landing with his knee almost fully, maybe at 10 degrees of extension. So he was hitting the ground really hard out in front of him. So one of the things we worked on with him for a while was to, again, bring his heel strike back underneath of him a bit more. Also be able to absorb forces and recover faster. And what that allows him to do is just dissipate forces and not hit the ground quite as hard. So he's still stiff and kind of age appropriate. He's about 64. But he actually absorbs better than what you see most people. And commonly what you'll see here too is that toe off and heel strike generally occur pretty close together. Like these older runners,
it's a short flight phase.
It's more like a jog, and that's what you'll see in any of the Masters runners. Is that flight phase almost doesn't exist. So on the EMG curves, it kind of becomes this blend between walking and running. When you look at muscle on times, like certain muscles, like gastroc soleus, will be on a bit longer and more delayed. You know, soleus on time and gastroc on time is a little bit longer or delays into it, because in running, gastroc soleus is more in early to mid stance and then tailors off in late stance. Where in walking, you have gastroc soleus is more active in later stance in the later propulsion and push-off phase. So in a runner like this, they tend to kind of drag out that gastroc soleus phase. Let me play this on. So there's the slow it down. That's kind of a mid-stance phase where you can kind of see just the amount of flexion he has. And it's not significant from where he started. But a much better knee recovery angle. When he first came with me, is basically his knee was never getting to 90 on his swing leg. He was just trying to, what he ended up doing is just dorsiflexing his foot and kind of coming through, but you also stay a little bit more rigid because having this leg not open up as much, you don't flex as much to the hip and knee and ankle. You're trying to run tall, so you don't have to do a large swing of the leg. So it also dictates how much force you may be willing to absorb through the body. That's his strike point right there. So with this, his heel is a little bit, as his first loading phase is, it's pretty close where you want it just right out in front of his center of mass. mean, ideally, center of mass would be a little bit further forward. But
Yeah, it seems like he's almost leaning backwards.
That's pretty typical. He's still pretty far back, but it's kind of it's tough to tell in a still shot because you kind of can see it looks far back, but it's also about how fast his center of mass accelerates over his foot, his base of support. So when you look at like elite runners, like marathon runners, like they're striking way out in front of them. By the time they load their leg, their center of mass is over top their foot. Even though the heel cushion in their shoe make contact out in front of them, the acceleration in their body mass is moving so fast that in the loading phase, they're actually loading right over top of their foot. A little faster one here. It's hard, maybe a little harder to pick up. You see him here, doesn't look quite as bad, but I would still like his center of mass, his hips a little bit more forward. You can even see it here, how he's a little bit more bent at the pelvis. The toe off. Again, going back into mid stance where he's there. You know, swing leg is higher than normal. So just knowing that stiff profile of that runner, you know, the same thing, you'll see the stiff profile. You know who else looks like this? Your typical triathlete coming off a bike. You're a triathlete who trains a lot. They run in this older, stiff style. They'll talk like the triathlete shuffle, they'll call it. But if you really kind of look at it, what they're running like, somebody's very stiff and somebody who's basically here. Not your elite guys. Your elite guys can kind of do it all. But your average age grouper, they tend to appear that way. I'm going to go and pull up see if I have another one. Masters female. Process.
Masters female about Kara's age.
Yeah, exactly. So 32-year-old female.
I woke up like that. I woke up feeling like Masters this morning.
Mm-hmm.
Just you wait.
And this style usually comes from ovary dehydration around the age of 32. Sorry, same view here. It'll slow down a second.
How old is she actually?
She is 55.
Oh, wow. That's pretty good.
Yeah, she'll win her age group in local Ironmans and other things too. So even if you watch her run, let's see, I got it slowed down here. Let's see this here, yeah. Sorry, I was playing with these videos last night, so some of them haven't got them all quite organized. But you can just see how stiff she is in different phases. You know, pushed off the heel strike again, very close. You know, look at the knee angle, not very well opened up here. I've seen her in the past. What she tends to get is she'll get her left hip is probably getting degenerative, and what it'll get is she'll get stuck again anteriorly. Her left hip, and it'll beat up her back. So she'll come in, and she may have some glute or groin pain, but most commonly what she gets is left-sided lumbar pain from that hip jamming up and trying to drive through it. Her spine is also pretty rigid as well. If the video is a little fast to pick it up, I'll have to cut one that slows it down. But her thoracic spine kind of moves as a unit when she runs.
It's so common among distance runners, though. Anyway, even you know, not at this age, even in, you know, kind of their 20s, 30s.
Yeah, you can just see that kind of stiffness that she has, where it's a lot of arm rotation. In some of these views of the arm, you can see that it's like, you know, the arm is rotated, but you see the whole thoracic spine as a unit just turns. You see, even in loading phase here, you know, this is second in, her knee recovery angle is not quite as high as it could be. And just the open angle happens quick. You know, in elite runners, what they look for, I'll see if I can find another video of her.
Okay. Like that last picture right there, that last still frame right there, almost looks like she could just be walking.
Yes.
That's how short her stride is.
Yeah, that's what happens is people age. They with the stride from 20 to 60, the stride shortens by like 13%.
Yeah, it's not more than that, but
yeah, so was I. You know, and you can see there how she's still stiff. She's getting full extension on that left side, but again, that's probably what's happening is that hip. Oftentimes, she doesn't get full extension out of it, so she'll take it from the back. Now, if I slowed it down more, what you can see sometimes is she may get a bit of a flexion movement. So that hip gets stiff, she'll take her lumbar spine, extend through there, while she's also trying to get very rigid and rotating.
Yeah.
And think of the upper thoracic spine as being, I'll talk about it, as she gets stiff up there, is think of that as a stiff mass balanced on L5 and driving forces down. That those discs in the thoracic spine should act like a spring, and it should be a shock absorber and attenuate forces. But if you put a fixed basically block on top of the lumbar spine, now you have this fixed mass coming down on it like this, not compressing and giving and compressing and giving. So it kind of adds to some of the back problem probably in her that, if she's not getting good enough rotation in the upper spine, spine's just moving as a rigid lever, then it's going to drive forces into her lumbar spine and down through.
And it's definitely going to make her use more muscular effort.
Mm-hmm.
Now she's not getting that spring right out of the thoracic spine, so she's got to drive it from somewhere.
Yeah. Look at her.
Lower extremity energetics.
Mm-hmm. So, and it's a thing I can kind of get, because they talk about, it's that part of that trade-off, like their ground reaction forces go down. So she does this. Like she's landing midfoot, by the time she loads, aging runners tend to kind of choose a style which will decrease their ground reaction force because the joints don't want to absorb the force. I think that's what happens to us. I think we get a kind of sense of the irritability that happens in the aging runner. It becomes articular. And you get a sense that now my joints don't particularly care for the loading. So you see this older runner adopt a style which will decrease the vertical ground reaction force coming in, so the joints don't have to take as much load. The guy previously had a running style which actually accelerated the ground reaction force in his right leg where he had the knee pain. So landing kind of stiff on the right leg with a heel strike actually will drive more ground reaction force into the leg and into the knee, hip, and ankle, which was driving his pain. So moving him to strike more underneath of him, get a faster turnover. And I also worked a lot on just recovery, being able to recover with the knee at 90 through mid stance, and drive the hip forward a little bit further, and then bring the tibia down more vertical. So all those things should decrease the ground reaction force, but made him move more efficient. So when I do speed training with anyone like this or retraining, speed training becomes just those simple mechanical changes should make them faster. I don't try and say, okay, now run a 630. It's here are the mechanics that I want you to work on. I want you to work on hip drive, getting your foot off the ground a bit faster, making sure your knee's coming through at 90 degrees and you drive your knee forward to maybe 30 degrees of hip flexion. And then you open the knee and place the foot. So the gait mechanics have to go faster, but again, having that knee flex through 90 also decreases the lever arm, like let's say hamstrings. I think hamstrings and these guys have to decelerate the leg more when the knee opens faster. So for like her, for instance, in this frame, if that right knee is opening fast, the longer lever, having the foot further away from the hip. So the work on the hamstring is going to be a little bit greater at some point because, again, that just the weight and distance of deceleration of the leg.
Yeah.
So sometimes if it's a proximal or a mid hamstring strain, it's one of the things you kind of play with is getting that knee up to 90 degrees through the recoil, not through active contraction, and then placing it down faster. You don't have that deceleration moment isn't as great on the hamstring. Does that make sense?
Yeah.
Whereas if my leg is swinging and my knee is straighter, it's going to put more demand on my hamstring because the lever arm is longer.
Sure. It's just more tension because it's going to elongate a little bit faster.
You got Shirk, even compared to him, I mean, in a video frame that seems reasonable, like right there, like see how her knee flexion isn't all that great. If I can measure that angle, I don't know, but no. See, let's see if I can stop her in another frame. Flight phase. There. Let me see if I can go back one.
So you compare that to someone who, for example, has a very weak left hip and their right pelvis is dropped, and so they have less vertical distance to pull their leg through, and they're overactivating could they overactivate their hamstring to keep their knee flexed enough to pull it through in swing phase?
What you should be doing is activating your hamstring in swing phase. In the early swing phase, your hamstring should be off. Your hamstring should be active, basically kind of through mid stance a little bit. It gets a little peak, and then it deactivates in late stance.
But you're saying if you have less knee flexion, through the stance cycle, then the eccentric control of or the eccentric need on your hamstring is greater.
Oh,
because
no.
Is that
what
you're
I
saying?
was saying is, think of the swing leg. The eccentric demand on the hamstring would be less if my knee is flexed more. Because so when my foot comes off the ground, the natural recoil pops my hamstring up in the air. So when I swing my knee through at 90 degrees, it's going to be less stressful. Let me find the frontal. Hope another one here. Hold on. It'll be less stressful. Where if my knee is a lower swing angle like this coming through, then it's harder because it's a long lever. But if my knee is at 90 degrees, if my recoil to my knee at 90 degrees is that if I put fulls on the ground, it pops up here. This is a shorter lever to then place my leg here. Whereas if I swing through here and do this, that's going to be a harder eccentric moment on the hamstring. This is too fast to pick up, so I'm still processing this one. But on her left side, she's going to strike more in the middle. So her hips more adducted on there. She'll get an eversion moment in her ankle. And I'll pull up the image right there, pelvic drop. So you have eversion of the ankle coupled with pelvic drop in her as she gets on that left side with side bending of the trunk. Come back one more frame, see if I can get it back here. Loading. That one. Right in there and collapse. So you can see how the angle of her leg, her right leg has to swing to almost clear the left leg. Because in mid stance, look how her foot is in the middle of her base of support. Can you see the angle I'm talking about? From her left heel coming up right about her gluteal region. That side bending moment. Her pelvis will drop this way. Her center of mass line moves too far over here. So she'll end up kind of leaving a little side bend moment with her trunk, which I think you couldn't see in another video very well, but in this particular image you could see it. So it's a little dark here too. So there's also a rotational moment. As her foot she loads. Let me see where her loading phase is. There, the foot inverts. And I believe the knee also immediately rotates. So the knee immediately rotating would also show, okay, is the femur following the foot? So she's going to invert or evert. Foot collapses. Tibia internally rotates. Femur can either torsion out like Matt does. I think Matt does this, and you see his knee stays straight. So for his knee to stay straight while his foot's collapsing in, he's either got to control it from the foot and adjust for it all at the ankle, or his tibia goes in and his femur's got to externally rotate on the knee and create a torsion. I think Matt's occurs completely at his foot. You're good. So it's just nice that you'll see his multiple kind of inversion style, but where she collapses differently than Matt. Her whole lower extremity will follow it, the collapse of the hip. And again, you can see how it'll drive forces up into her lower back. So typically what happens is, with her, I'll do that. I'll mobilize her hip because she'll come in 15 degrees of hip internal rotation. By the time she leaves, I can get her to usually do 30, 35 on the first visit. Okay. If the SI joint is off, I'll get the SI joint. I'll work my way through the lumbar spine. Sometimes L5 is jammed, sometimes it isn't. Then I needle her back, just reset the tone, sacral multifidi, gluteal muscles. And that takes care of the kind of the wind up that she'll get. And of course, they think the needling is what fixes them. So she'll come back for the needling, and then I'll fix her real problem with the manipulation in the hip.
Well, I try and avoid needling at all costs.
Not me. Whatever keeps them coming back. I have no soul.
I mean, what else do you do to reset the tone then? Or I mean, how much, if you were seeing 30 patients a day, how do you have time to do all that?
What do you mean? Do all what?
If you wanted to reset the tone, if you wanted to do everything that Dave just described without needling her, what other techniques would you use, or were you purely manipulation? I mean, I
Well, the
can't really
manipulation
picture
will
you
reset
like,
the tone on its own.
but will it, I mean, will that manage the, like a pain generating trigger point as well over time?
Actually, it'll
Like if you,
manage it better over time.
The manipulation is what works better over time in resetting it. But where I'll use the needling is it's down ramping in layers. So you can get the joint to move well, but the nervous system just hasn't completely adjusted yet. It'll wind down. So what happens? Good manipulation is that, okay, if I just manipulate and leave them, it's like, oh, how did you feel later that night? It's like, oh, later that night, just kind of really eased up and felt much better. That's the mechanical effect. You know, so if I know that, but if I needle them right away, it accelerates that mechanical, that release. They don't have to wait those few hours for the nervous system to unwind. The muscles go, oh, it's okay for me to move. It takes a little bit of time for that unwinding, you'll see sometimes. So that's what I look for. If they come back in the next day or 2 days later and like, you know, it felt better for a little while, but then it kind of came back later on that night, then most likely the effect I got from manipulation, I think, is neurophysiological. So I will recheck it to see if the joint's stuck again. It's not that I won't manipulate them again, but the cursory screen is if it lasts, usually I know, okay, I'm pretty sure that was a mechanical effect. Let's clean up motor patterns now because that joint's good. I fixed your second rib. Your pain's gone down considerably. Let's work on the thoracic mobility problem that's probably underlining this, doing it. But I will use that needling, you know, basically right after the manipulation as a carpet bomb. But sometimes I won't. If I think this person's totally going to think it's the needle and not me manipulating them, I'll needle in the second session. But if I know them and I know a lot of my patients, then I'll go ahead and manipulate them and needle them because they're expecting kind of the package. So
yeah, and I think I said this on one of these calls before that I think needling's still a good tool to be able to use, but in general, if I have somebody come in on their first visit and I do a needling session with them, that's all they're going to want when they come back. They're just going to be like, just jab me with a few needles and I'll be on my way. It's just like, well, you're not going to be any better. You'll feel good for a couple of days, but then it's going to come back because, I mean, let's face it, if we're dealing with somebody that's coming in with a lot of these trigger point issues, these trigger points are typically caused by a facilitatory effect, right? So this is that central sensitization stuff that comes on. And if we don't correct whatever the abnormal feedback mechanism is that's going through the spinal column, through that reflex arc, the needling is only going to be a Band-Aid. It's only, and at a certain point, we're going to hit that chemical gradient where now the needling is no longer going to release that electrical component, right? So we're not going to get that muscle spindle to release the way that we want to. So the effect of the needling is going to diminish pretty rapidly. So if I'm going to needle somebody, if I have somebody that, you know, really does well with it, then I try and limit that sort, especially somebody that has a motor pattern issue like a runner or swimmer or something like that, or a overhead athlete, then I'll try and keep that needling to 4, maybe 5 sessions, depending on how long I'm going to see this person for. I have a few chronic pain patients that I will needle more consistently just because they need those couple of days of relief whenever they can get them. But in general, when I'm trying to re-educate a motor pattern, I want to do it without the needling just because the needling is, it gives them this false sense of security, right? That it just gives them this false sense of like, if I just get this done twice a week, every week, I'll be able to run forever. And it's just like, well, no, because you're still getting all of these tone issues, right? And so you're gonna have all these secondary problems that come along with facilitation as well, where you're gonna get these pseudotendinoses and all these other sort of things that kind of come along with it. And eventually it's going to start to wear out some of the structure of those things. So for me, it's just not something that I want to do a ton of all the time because it's problematic from a mental standpoint for the patient in these sort of situations. Chronic pain, it's a different story, but
yeah, it doesn't replace the other neuromuscular retraining and the importance of that aspect of it. You need to fix the patterning that's driving it.
So I guess one of the other things I wanted to talk about when we had a moment, and it doesn't have to be today, but like age appropriateness for mobilization and manipulation, especially for like, I would say women into their 50s, 60s, 70s, you know, the considerations for that and any reason, you know, I mean, we should not assume that every woman in their 60s or 70s has like low bone density, but how do you know, kind of assess for you know, how aggressive can you be, basically?
It's probably something that, you know, again, you don't get it much from in the gym, but, you know, you think about your different barriers. And, you know, we're looking for manipulation. We're always looking for, okay, what's the end feel like? And for a lot of those women, you start to think of, okay, now what's the end feel? It's what's your first tissue resistance? Maybe your R1, your R2 in those individuals. So if I come onto the rib and I'm checking the rib or the costotransverse, costovertebral joints, I want to feel, okay, where's my first resistance? Is this just stiffness in this joint? Where's the restriction? You know, I think in that layer, I'm not going so much to, okay, I want to see what the end feel is, but how stiff is this segment? And I use the osteokinematic and arthrokinematic glides and like the assessments as my treatment. And for those women who are a little more fragile, I may take them through that. I know that, okay, if I rotate the rib cage to the right, you know, my right rib should swing backward, kind of like the innominate would go. So it's going to glide posteriorly. I know I'm going to translate left, maybe side bend right, or side bending can be anywhere depending on where that person's probably rotoscoliosis is going to take them. So they're probably off center at that point. But I will follow the ribs and say, okay, can I get this ring and this segment to move? Can I apply the osteokinematics, that rib between the translations, the flexion extension patterns of the facet joints, and the rib glides? And I'll treat the glides if I think they're fairly fragile. I will use my thenar eminence sometimes as a foam roller with proprioception. I will roll them onto there as if I'm going to manipulate them, and I will just get the feel. I can side bend them and take the rib inward. I can then pull the rib and distract the rib a little bit. I can glide it up or down. I can do the same thing. So I can put proprioceptive input and get a sense of feel, like how does this rib move when I get the weight of thorax on it.
This is in the supine technique.
Yeah. So with all the ribs it's multi-segmental restriction is what they'll have. You have multiple segments which are stiff. So none of it's going to feel good to them per se, unless you go soft. And that's where the seated technique, where you can glide and rotate and flex, extend, and try and guide the osteokinematic and, you know, motions, is sometimes helpful. Supine techniques can feel, may feel slightly aggressive to them, but I think if there's one segment that's not moving well, or with one segment that's off, think about that natural barrier. I'm not going to go in here and manipulate it, but I'm going to take this joint in all the directions it should go, and can I guide and facilitate it through its normal pathway? Does that make sense?
I mean, it makes sense that it's based on the end feel, because we're not going to manip something that feels
so you're thinking that R1 or 2
anyway, but you know, and it's probably slightly to tolerance, right? Like, if it feels really crappy to them, I mean, it's probably not going to feel great, but I think stiff and productive is a different feeling than like, oh, I think my bones are going to break.
Yeah, exactly. And you should be nowhere near there, because you know it's going to happen. You think, oh, I basically want this one unit to be able to glide. Can I take that, either the ring or the one rib, and can I take it and will it move within what it's going to give me? Figure out, okay, what's this rib want to give me? Let me go with what's going to allow me to do. And then maybe I work into arm overhead or flexion extension pattern. I may block the bottom facet and say, okay, can they get proprioceptively pull over top of it? Because many times they'll be stuck, probably flexion, and they'll have 25% more extension than they're using. And how do I block it and get them to use that extra 25% of the range they're leaving on the table? And that's the margin. That's when they start to feel comfortable, because you expand their ability to use their available range, which I have to almost do it segmentally through, because it's kind of shut off in them.
Got it.
I do that pretty much exactly the same way.
Do you? Good.
Really no help with that.
That's a shame, because I was really hoping you have something different. I love it when you come up with something different, that I can go back and play with something. So that's disappointing.
No, yeah, I mean, as far as, you know, patients that are, you know, you're concerned about some sort of fragility, you know, that's those seated techniques. And I use some locking techniques with it, you know, kind of translating above and below in order to kind of create some of those sort of things. And so there's a little more, maybe a little more involvement with how I do that sort of stuff from a biomechanical standpoint, but it ends up being the same sort of idea.
So the seated techniques that you're talking about would be kind of like how we were assessing for like latection and rotection.
Yes. Where
you could extend them and side bend them left and
Yeah.
or right or okay.
Mhm.
Yep.
And that's probably gonna. I mean, that would be safer and more tolerable than
Mhm.
the supine techniques because you're not putting as much force through it.
Yeah.
Yeah. I mean, you can always check rib spring or rib cage expansion and rib spring to see if they're capable of tolerating something a little more aggressive.
Mm-hmm.
You know, that's always an option, but for me, I've always found that's because that's supposedly one of the first things that goes is that chest wall expansion, and when you start to lose those trabeculae there, and so it's just that kind of like, how much elasticity do they have in the rib cage? Supposedly that's one of the first things that goes with an osteoporosis, osteopenia situation. But I find that a little bit suspect to count on that sort of thing to protect them and me in a situation where where I want to try and do something more aggressive. So yeah, I will check it because it's a good safety check to be able to put in my paperwork, but at the same time, I'm not hanging my hat on that sort of thing all the time.
So how would you document that?
Positive rib spring, something like that, because it just feels like a plank of wood. There's no compression to it.
Got it.
Yeah, for treatment too. I mean, mobilization with movement, therapy, or often what I'm going to add to it is they're going to be here, they're going to be here. I'm going to work on extension, rotation. It can be the same thing, or you can look at side bending or rotation. Usually I don't go flexion because they're already here. What I want them to be able to do is, can I get those segments and extend it as they can? Then can I rotate from extension? Because normally they'll be flexed and they'll flex and rotate. So can I find the extension moment and then have them come left or right? And in my hands, I'll usually try and get on the ribs and I'll try and guide them. So I'll find a lower pole of the rib with my index finger, walk my thumb up the rib. So the configuration will be somewhat like this, which you find the rib plane. And then can I take them, kind of guide them into that rotation? Then also have them use their scapula. I'll lead with the scapula. We'll pull from top down a little bit better too. So if I want to get work to rotation, you can get on the ribs, guide the rib into the rotation direction I want it. So you can get that to move a little bit and give them some proprioceptive input. So that in my code is even neuromuscular re-ed.
Yeah.
Okay.
The only other thing that I throw in there with that, because I'll do that same thing where I grab a hold of the ring. So basically I'm kind of on the lateral margins here of the ribs, is if I see something there, where I'll actually physically try and correct them. And then I'll have them take some breaths in that position. So basically I'm trying to stack the rings. This is a Diane Lee thing. So if you can try and stack the rings up and down, then that respiratory mechanism will help to kind of reset some of those motor arcs as well.
Okay. If you do find, because I treat a lot of really active people in their 50s too. I mean, if you find a pathomechanical end feel, is there any reason not to manipulate them?
No. I mean, unless you realize, I think you go with your gut on this one. Is this somebody's off? And sometimes what I do is, I'll thrust them. I may set them up as cleanly as I can and just lean into it and see if it'll go. Or flex and side bend them left and right. And oftentimes you'll get that joint to go.
Yeah, I've done it hundreds of times.
Yeah.
And it's all about the setup. I mean, it's kind of the same deal as manipulating somebody that's, just kind of hesitant about being, having their back cracked and stuff like that.
Yeah.
It's like, well, we're just going to set you up and we'll just have you take a breath out and we'll just kind of take up the slack and see what happens. And, those are the ones where you kind of really focus in and you're just like, all right, here comes my barrier and here's the breath out and pop. It's just like, that wasn't so bad, was it? You don't have to jump on them then. You don't have to produce the thrust yourself. It's just the body does it on its own.
Yeah, I feel like I'm just like in a manipulation shy period right now that I'm trying to get myself out of. So, basically, like, I don't want to be nervous to manipulate everybody. I think whipping that lady's ankle and messing up her back really set me back mentally. And I'm like, okay, don't be a wuss, Tara. Like,
no, just add a 25% J stroke and it redirects the force.
Yeah.
I taught that this weekend, by the way. I spoke about you.
Oh, cool.
I included you in the course. Like, oh yeah, just recently I was talking to somebody.
Well, I'm glad to give you some ammunition.
I got to roll, guys, though.
Okay.
Dave,
All right,
I'll talk to you tomorrow.
Tomorrow, sounds good.
All right.
Thanks, Eric.
Yep. We'll see you, Kara.
Bye. Do you have to go?
I got till 2:15.
A couple more minutes. Okay. So to follow up on that, we learned the like pre-manipulation tests for thoracic spine is like the shear along track sign and then the thoracic slump.
Mm-hmm.
So like what happens if because I have a girl, she's like my age, she has 2 young kids, she co-sleeps with them, and she's always a mess. And I'm pretty sure it's very, I'm sure it's like cervical thoracic, you know, she has like elbow and wrist pain and problems. And I think she needs a lot of work there. But when I like did all that, she seemed stable in her thoracic spine. And then she's got like her left quad reflex is like 3+ or something, you know, a little extra or like asymmetrical. So when you know, if you have really clean everything negative, then yeah, go ahead and manipulate them. But if you have something that's like a little muddy, then how do you tease out like that's incidental or not?
So she has a slightly brisk reflex, or a brisk reflex. If you're thinking,
I mean, it's not like.
Because yeah, I mean, it'd have to be something to make a reflex kind of higher. You're thinking, okay, is this upper motor neuron, or is this just slightly facilitated where she has a brisker reflex?
Yeah, I mean, she also has lumbar dysfunction and a lot of like hip and knee problems. So I'm like, is this? Basically, I'm trying to figure out if she's safe to manipulate, and then that would be like for a thoracic spine, and this can flow into next week. But then, would a distraction technique be safer for her than a supine technique? And then B, would a rib distraction technique, because that technically is a different angle of thrust and it's not shearing the thoracic spine, would that also be safe?
The easiest one to do in the middle things is just the seat attraction. It's just to lift and think of, it's not so much that you need to think about, okay, I need a big thrust here. It's just a matter of, can I lift this segment? And think about lifting, if she's smaller, the bottom segment. Get the towel above there and think, okay, I just want to distract the bottom segment from the top. And you could almost just use a little bit of a jerky oscillation. Most of the time it'll go.
Yeah, she's really small.
If it's really restricted, you'll feel it's like, oh, this thing is just, once I get it up here, you can tell it, oh, this is an abnormal feel to it. The spine doesn't elongate. It should elongate through as you pick them up. You feel it stretch, especially in their 30s. When it doesn't, when all of a sudden she comes up like a unit, you know, okay, this myofascially, she'd have to be pretty charged up. But more likely, you probably have a stuck segment right there that you feel that the force doesn't pull through that segment. She's somebody who I would do it pretty cleanly on, or pretty quickly on. If you're feeling almonds, I'm not sure. The thoracic segment will probably give you more bang for the buck. Like, when I cautiously, you know, step into the water, then what I would do is I would take your hand and I would go through and I would set up for the rib manipulation, the distraction rib manipulation. Roll her over, start on the lower ribs, and what you should feel is as you roll her onto that rib should move. The rib shouldn't have any problem gliding. And then when that rib moves well, and then you can push across the body for basically the ventral glide, and then you have the lateral glide you can do, pulling out, move to the next rib. Go up and down the ribs. At the very least, it's proprioceptive input, and the 32-year-olds don't think that feels really good. Because you're stretching the ribs, the capsules, everything around it. Gets a chance.
Well, she said it felt like shit. I mean, it's
really?
like stiff. Like she is very stiff. So we get her set up, because I did that. I set her up to do the rib stuff, not a thoracic distraction, supine or thoracic anything. But I just set her up thinking, even if I'm not sure that her nervous system signs are good, I can at least like check how these feel in that position. And she was like, well, that feels like stiff and like crap, but like what needs to be done.
Yeah.
So
that's probably a good sign. It's probably, you know, you're on the right track. When you load somebody up there stiff, they're like, oh, it's uncomfortable.
Yeah.
And then I know, okay, maybe I want to get in and out of this fast. Or I'll roll them onto my thumb, you know, and it could be just pressing it. It could just be just a quick press and back out of it and see how she responds.
Yeah. She was pretty sore after, and when she came back a couple days later, because now she's starting to get like jaw pain. I'm like, literally, I'm treating this girl like head to foot, and she has tarsal coalition, so literally head to toe. You know, and it's hard because she's so sporadically in here. She works from home every other week because of the building is closed, or her work organizes like that, and she doesn't really have any time or prioritize taking care of herself.
Yeah.
So I feel like the only thing she does is come here, and then how much can I actually accomplish in like 30 minutes or whatever. I mean, yeah, I know I can accomplish a lot in 30 minutes compared to other PTs, but like, where am I? I feel like I've just been chasing it a little bit with her because
you're treating her with one arm behind your back.
Yeah. Is that a joke?
You need to kind of get in there gently, and that's the thing, is think about it not so much as I need to go in there minute. Apply the joint mechanics to it. Go in there with a little bit of pressure, and then you can decide, okay, yeah, I need to go a little harder with this. So let me pick seated traction. Let me do the rib glide. Seated traction is a good, intersegmental technique, general, but many times it gets it done, especially in a 30-something-year-old.
Yeah. So would you block the top or bottom? I mean, you could do either, right? You could block the bottom segment and traction up, or block the top segment and let gravity drop it down, right?
Yeah. What I often feel is that it's like the gravity drop technique on there, I get a sense of how much does the spine elongate. Like, maybe is there information there where you put it in a certain spot, like, oh, I pick her up and her spine just comes up off the table, or does it slinky a little bit? So like the triathlete that I showed, with her spine, I do that to her. I pick her up. It's like she's glued together. I don't think her spine slinky or separate at all. She just comes up as a unit. Whereas somebody like her, you may start to pull up and her pelvis stays on the ground for a little bit as her spine elongates, and then once everything gets taut, and she comes up, and that gives you an idea of just the level of stiffness.
Okay.
So interestingly, somebody that comes up all at once, multi-segmental stiffness, probably not going to go that hard because probably multiple segments that are stiff. This isn't a classic sublux joint, or there may be one hidden in there. So it's a little hard to tell. Your girl will be like, oh, this feels loose. Oh, this spot isn't moving like the others.
Stiff. Yeah. So would a brisk reflex preclude her from manipulation otherwise?
That's the only finding you have? No.
Okay. Well, I had forgotten what the third thing was, and on our call, I remembered that the third thing was the thoracic slump. And that's where you keep lumbar neutral, right? And slump thoracic.
Yeah.
And then they should have no like groin or back pain, right? Like that's what the thoracic slump is. Okay. And the seated shear, where you're just like, right, basically key grip here.
You'll find something almost in everybody up in the upper, they'll have one segment in the upper thoracic spine, which is positive with the shear for just movement, not necessarily pain, but movement. You all have that hinge segment somewhere. It's very common to find.
So just don't manipulate that one.
Yeah, don't manipulate that one unless you come back the next day and it's stuck, and then it's like, okay, this hypermobile joint is now stuck. And then do it gently.
Because it's not a contraindication to manipulate a hypermobile joint as long as it's stuck in a direction you can manipulate it, right? Because if it's hypermobile, it's probably going to go out faster.
It's going to go in and out and in and out. Yep.
Yeah, but then it probably won't need as much force.
Correct.
Right? Okay.
Yes.
So if her thoracic slump is negative and her shears are good, and she just has a little bit of a unique reflex, that's not something not to manipulate her over.
Yeah, no.
Okay.
And think of yourself as a soft manipulator. You get in some of these joints, go in there and apply the technique. It doesn't have to be a big thrust through people. Set up the osteokinematics, set up the direction you want, and just think of like just soft thing. So I started to think, if I get better, I should get softer. And I think I've gotten softer over the years just because I can, I'm going to set it up where I want it. I can lean into it. And then I can just think of it as a small impulse, even if it's just like a little shake like that. Once it's loaded, it's enough.
Yeah.
It doesn't need to be a big finishing blow.
Yeah. Okay. Yeah, I think she really needs that. I got to recheck her neck too, because I'm sure that's where it's all coming from. But
yeah, and especially onco-vertebral glides. Just think about just gliding. Okay, the down glide, where extension and medial glide, just working onco and facet joint. So extension, down glide, up glide, and flexion, on each side. Just get a sense of the rolling glides. Just taking your hands, I'll just roll down the neck a little bit and say, okay, here's the one that feels a little stuck. Maybe I wobble it right, get it loosened up.
Because that's indicated when a segment is hypomobile in flexion and extension, right? And then you can go and do a more like basically block from the other side and block the top, do a down glide, or block the bottom and try to up glide it.
Think about also that the anterovertebral and the facet joint, they're kind of working together as a team. So many times that down glide feels restricted. It's probably gonna be anterovertebral. Like that facet joint may move, but it's probably the combination of those two. You may not be able to tease them out. You may find more oncos just because the nature of it being more limited to be the more restrictive joint. Certainly in the 40-year-old, I think it's the more restrictive. Those oncos start to spur up. You know, space closes down there. You know, those are the ones that get restricted, and you lose side bending. And I think you see it more in females and males, just maybe the size of the neck and the size of the joint.
Yeah. Do you have any good like cervical manip courses that you would recommend?
Yeah, go back and do the next one course with Eric.
No one tells me when they are.
Remind me.
I'm starting to think that you don't want me there, and then I won't go. But
no, I'll look up the dates.
I'll look up the dates, because that's still something that I would really like to. I just don't feel like that confident on. So
now look at the dates for it, and we'll see that's what you go and do, because the techniques you're familiar with, he'll refine it for you. You have Matt there to do it with and practice with.
Yeah, I'd really like to prioritize that, because that's something that I definitely don't do enough of, and I know it's really important.
The last one was August 28th, so that should be coming up in the end of October.
Yeah.
And Eric's teaching. So just I'll email you to Eric. Eric will know the dates off the top of his head. I don't recall them off the top of my head.
Okay. Do you want me to email you to remind you about that, or?
Yeah, just email me after this, and then I'll just reply it over.
Okay. I don't need to participate. I just like to sit and absorb or be partners with Matt.
That's what you do, is you just go in there and you can be partners with Matt, and you practice the upper techniques, and you just take the technique list and go over it. You two can just work together. It'd be more interesting for Matt that way, other than just, okay, I've done all this and now I'm doing this again.
Yeah, is he the only fellow in the course, do you know?
Probably.
Is this number 6? 6.
Okay.
Cool. So I could probably grab the last couple. And then
I can send you a technique list to work through. So if Eric's there, I can send you more advanced techniques for like module 9 techniques. Oh, and let me know when you're moving to Alaska, or let me know when you're going to give them notice or so.
Yeah.
I thought about coming out there, maybe just doing one day of advanced techniques with you guys, just for fun.
Yeah. Oh, that'd be awesome. For our weekends that I did with the last cohort to count for my continuing ed, do I have to do anything special?
No.
Like Nick said something about having to redo all the quizzes and stuff on Moodle.
If you want the certificate, you have to do the quizzes in Moodle to print the certificates.
Yeah, but I did that for the first round.
Yeah, so you shouldn't have to. But if you want the count ed hours again, you should just be able to print the certificate, or say to me, hey Dave, this certificate, the date on it's wrong, and I'll get you a new certificate.
Okay. Just in case I get audited, because I'm using all of those for my
no problem
hours. I just didn't know if I had to like officially do anything on Moodle, because all of my Moodle quizzes will be from like 2016 or something.
No, I'll get you certificates for the classes.
Okay. Cool. That takes one more thing off my list, because I'm like, if I have to go back and redo that, just like I renewed my license and I talked to Nick about it, and he was like, yeah, you have to do this. I'm like, well, I already renewed my license and said it's done. So I don't know if I'm like up the creek because of that. So, okay. Cool.
All right, kiddo. I gotta get going. I got my next Zoom meeting. Yay.
All right. Thanks a bunch. We'll see you next week.
No problems. Good talking to you.
Bye. You
Take
too.
care.